Excellent. Thank you very much for asking us to come talk MCHP, and those of you that are joining us for coming to listen to us talk about type 2 diabetes in Manitoba. As Marnie had mentioned, this research, as most research done now at MCHP, is done in partnership with Indigenous partners. Lorraine McLeod was one of our partners from FNISM who came to work with us on the type 2 diabetes in Manitoba deliverable. She was unfortunately called away to another meeting this morning, and so it was unable to join us, but she has participated in the putting together of the slides and of course throughout the deliverable to help us, interpret the results in the context of the First Nation peoples of Manitoba. So, as most of you are familiar with MCHP research, there were many people that went into the writing and the research that was involved in producing this report. And so I'd just like to acknowledge them here. Before we continue on, Liz would be very annoyed at me if I didn't make sure that we all were kind of on the same page about diabetes, because there are different kinds of diabetes, and this report focused on type 2 diabetes. So the two kinds of diabetes that most people are familiar with outside of pregnancy are type 1 diabetes and type 2 diabetes. Type 1 diabetes makes up a small proportion of the diabetes in the population. It's an autoimmune disorder where the beta cells, which usually produce insulin, don't produce insulin anymore. It absolutely requires insulin. There's a genetic predisposition, and it usually starts in childhood or young adulthood. Type 2 diabetes, which makes up the bulk of diabetes in the population, is actually a different disease. It results from a combination of insulin resistance. So you have insulin, it just doesn't work as well. And then the beta cells that make the insulin aren't able to keep up with the demand for additional insulin. It has a strong component of genetic risk, but is certainly multifactorial in why some people develop type 2 diabetes and some people do not. It's often, but not always, associated with obesity. And traditionally, it was called adult onset and only seen in adults. But as we'll see in this deliverable, and as we know from living in Manitoba, we now see a lot of type 2 diabetes in children. The confusing part comes in that type 2 diabetes used to be called insulin or non-insulin dependent diabetes or adult onset diabetes, but those don't actually kind of explain what exactly it is. So today we're talking mostly about type 2 diabetes. So the report was a large kind of scoping report that looked at type 2 diabetes in Manitoba. We looked at the prevalence and incidence, the complications and mortality, the kind of traditional things that people look at when they talk about type 2 diabetes. We looked at the impact of type 2 diabetes across the life course, because as we see it in younger children, it starts to impact children throughout their lifespan, and then continues to impact adults as they age. We looked at some things outside the health services, some social services, some educational outcomes, some complications, and some comorbidities. And then, as we noted, we partnered with FNISM and First Nations partners so that we could look separately at type 2 diabetes in the registered First Nation population in Manitoba. Because in addition to having higher rates of type 2 diabetes than non-Indigenous Manitobans, of course, there are also the additional impacts of the Indigenous and the social determinants of health. So while there's a lot of granular detail within the report, there were some kind of key themes that came out when we looked at all of the data. One of, I think, the most concerning findings is that the population burden of type 2 diabetes continues to increase, and it's increasing faster in our youngest age groups. That the control of type 2 diabetes is poor throughout the population, regardless of where you live in Manitoba. That both rates of type 2 diabetes and complications of type 2 diabetes are higher in the First Nations population. And that many people in Manitoba are not receiving care as recommended by the Diabetes Canada guidelines. So we used a variety of methods to assemble the data that's contained in the report. The years vary a little bit depending on which indicator we were looking at. We did do a look back at any diabetes, so that included type 1 diabetes, type 2 diabetes, other kinds of diabetes that happen outside of pregnancy. going back to 1985, so we could have kind of a historical look at rates. And then the bulk of the report focuses on type 2 diabetes in a 6-year time period. We, of course, use the multiple databases available at MCHP, including the detailed diabetes in youth database that Liz Sellers' department manages, and the First Nations research file, which was how we identified registered First Nation peoples. We developed an enhanced definition off of the standard administrative definition that identifies diabetes to try to kind of narrow down our results to focus on type 2 diabetes, because it is a distinct condition apart from type 1 diabetes. So what did we find about prevalence and incidence? So we found, not surprisingly, that the prevalence of any kinds of diabetes is going up in adult Manitobans. So this slide starts back in 1985. So this is any kind of diabetes, but again, the bulk of this is type 2. And it shows us that the diabetes prevalence, so that's the percentage of people in Manitoba with any diabetes, is going up. And it's going up quite dramatically and continues to increase. Rates are highest in the Northern Health region. And then we have Interlake, Prairie Mountain, Winnipeg, and Southern. And it really just tells us that we need to continue to plan for people living with diabetes. When we looked at just type 2 diabetes, we found the same increases. We found that when you look at just the crude number, so the actual number of people living in Manitoba with type 2 diabetes was almost 15% of First Nation Manitobans and just under 9% of all other Manitobans. However, if you age and sex adjust those prevalences, as the First Nations population is in general younger and more likely to be female than all other Manitobans, the rate would be 3.5 times higher for First Nation Manitobans. We found no differences between health regions in the rate, in the amount of people living with type 2 diabetes when you stratify by First Nations and all other Manitobans. So whether you live in Prairie Mountain or the South, your rate of diabetes, if you're First Nation, and your rate of diabetes if you are non-First Nation, is the same. The other interesting thing that we found was that the total mortality rate was double for First Nation Manitobans compared to all other Manitobans with type 2 diabetes, which is very concerning. And again, this is just in people with diabetes or type 2 diabetes. The other interesting thing that we found, in general, when we look at mortality across the health regions, we see a gradient where mortality in the north is higher than mortality in the south. When we stratify for First Nation versus all other Manitobans, and when we are only looking at people with type 2 diabetes, that gradient doesn't actually exist. So your mortality rate, if you're living with type 2 diabetes, is the same regardless of where you live in Manitoba. This graph shows us where people with type 2 diabetes are living in Manitoba. So for all other Manitobans, the bulk of all other Manitobans with type 2 diabetes are living in the Winnipeg Health region. And the bulk of First Nation Manitobans with type 2 diabetes are living in the north and in the Interlake, which mirrors the distribution of people in Manitoba without diabetes as well. When we start to look at incidence of diabetes, the picture isn't quite as clear as the picture for prevalence. So incidence is the new diagnosis of diabetes. So this graph looks at the new diagnosis of any diabetes for adult Manitobans by health region. We do again see across most of our time periods a higher rate in the north, and then the kind of other three apart from south kind of cluster all together, and then the south, the incidence remains lower. There is this suggestion that maybe our incidence rates are leveling off, or maybe there's some more inter-year variability. But when we dug down a little deeper, the picture wasn't quite as clear. When we looked at just type 2 diabetes, we saw, and we're going to get back to the incidence and why the picture is unclear in a second. When we look at the crude incidence, so new diagnosis of diabetes, the discrepancy between First Nation Manitobans and all other Manitobans doesn't look quite as high. But again, once we age and sex adjust, it's almost double. So a First Nation person living in Manitoba is twice as likely to be diagnosed with diabetes. Again, we see no differences between health regions in incidence when we stratify by First Nation or all other Manitobans. So this graph shows us the incidence, so the new diagnosis of type 2 diabetes among First Nation Manitobans and all other Manitobans by health region. So again, we see the difference between all other Manitobans and First Nation Manitobans, regardless of which health region we are in. But then the picture gets more confusing. In some places, we seem to see that the incidence is going up over the 6-year time period. In some time periods, we see that the incidence suggests that it's going down. Because we're only looking at a 6-year time period, the numbers are a little smaller, so we may not necessarily see statistically significant differences, which is one of the reasons why the picture is a little bit confusing. But I think the bulk of the story about changes of incidence is shown in this table here. So when we divide by age, so when we divide our population into those under 30 years of age and those over 30 years of age, this is when I think the picture becomes clearer, because we see that for First Nation Manitobans under 30 years of age, the rate is going up. So there's more and more new people being diagnosed with type 2 diabetes. When we look at older people, the rate is going down. But that's, of course, because they're no longer at risk of being newly diagnosed with diabetes because they already were diagnosed with diabetes when they were younger. For all other Manitobans, we see a suggestion of the same pattern, certainly over 30, or sorry, I have a different pattern. Over 30 years old, our rate is going up. Under 30 years old, we don't show a statistical difference in the change in rate. So the rate of new diagnosis is remaining about the same. So this just tells us when we look at incidence, we really have to take age into account as well as somebody's cultural background. And now Liz is going to comment on the next couple of slides.
So, so this is, was I going to comment on this one? This is adults. I can. I think it's the one after this, Chelsea. Do you want me to comment on this?
I can comment on this one.
Yeah.
So this is looking at adult Manitobans by age group. This is any diabetes. So this includes type 1 diabetes and type 2 diabetes and other kinds of non-gestational diabetes. But again, this picture just starts to tell us the story that we were talking about in the previous slide with the incidence changes by age group. It shows us that in our 50 to 59-year-olds, our rate is going up. And in these younger age groups here, it's going up. And while it doesn't look like it's going up that much in our very youngest groups, we do know that because historically there wasn't as much diabetes in these age groups that this rate of increase is concerning. Now, Liz.
Okay. And I think, so we just wanted to share with you some of the pediatric specific data, having seen that First Nations people under 30 have the increasing rates of type 2 diabetes compared to all other Manitoba's people under 30 don't seem to have the same increases. And this is just honing a little more in on the pediatric age group. This is data looking at the incidence or new onset rates of type 1, and that's in the kind of the pale green from mid 1990s to 2017. And in the darker green are the incident rates of type 2 diabetes over the same time period, again, restricted to children under age 18 for type 2 diabetes. So just quickly looking at this, you can see that both type 1 and type 2 diabetes are increasing in children. If I focus on type 1 diabetes, this slow, steady increase is seen around the world. It is not unique to Manitoba. It's about 3% per year. And that's really what we've seen in Manitoba. If we look at the increase in type 2 diabetes, that slope is much steeper. And we are seeing a much more rapid rise in the incidence of type 2 diabetes over the same time period. If you look about 2010 onwards, we're actually seeing more newly diagnosed children with type 2 diabetes compared to type 1 diabetes. So this graph shows us that both type 1 and type 2 are increasing. It's increasing more, type 2 is increasing more rapidly in children. And compared to anywhere else in the country, This is unheard of, where we see more newly diagnosed children with type 2 diabetes. Can we have the next slide? So this is also incidence of type 2 diabetes in children in Manitoba, divided by health region. I thought this was, hopefully the next one is by First Nations versus non-First Nations. You can see by far the highest rates over the last 10 years are in the northern health region. Chelsea is the next one here.
No.
So if you just close your eyes to the title of this, where it says by health region, you can substitute the highest light green line as First Nations children, and just draw yourself a line that looks more like the middle green line. So in First Nations children, the incidence of type 2 diabetes has risen quite dramatically over the last 10 years, and is now at about 155 to 160 per 100,000 children, First Nations children per year. In non-First Nations Manitobans, it's also rising. It went from about 4 to about 9 per 100,000 children under 18 per year. So rising in both First Nation and all other Manitoban groups, but is dramatically high in First Nations children. And 155 per 100,000 is the highest reported by quite a bit ever reported in the world. And let me put that into context. So we teach our medical students that type 1 diabetes is a very common chronic illness in young people. Perhaps only asthma is more common. The incidence of type 1 diabetes in Manitoba and in Canada is amongst the highest in the world, between 25 and 30 per 100,000 children per year. So that is, I don't think you can see my pointer, but that is, if you think of 25 to 30 per 100,000 children per year in Manitoba are diagnosed with type 1 diabetes. In First Nation children, type 2 is about 7 times more higher than that, the incidence rate, at about 155 per 100,000. So pretty dramatic numbers. We do see type 2 diabetes in Indigenous children is higher than non-Indigenous children throughout the world, but our incident rate in Manitoba is, well, it is the highest that's ever been reported. And the next slide is just really a summary of this first part, where we see that type 2 diabetes is increasing, particularly at younger ages. And that may mean that we need to update our screening guidelines that tend to concentrate on the older age groups. The overall mean age in adults is decreasing, but that's driven by the young adult group. We know that in pediatrics, I've told you about 3 times now that unfortunately our incidence in First Nations children is the highest reported in the world, and it's now about 155 per 100,000. And but we're also seeing increased rates of type 2 diabetes in young people in pediatrics and the young adult group who are non-First Nations, going from about 4 to 9 per 100,000. And I think, Chelsea, I'm going to hand back to you.
You are. So that sets the stage for, the population that we'll be seeing with type 2 diabetes going forward. And so then part of the deliverable focused on whether people currently living with type 2 diabetes were receiving the recommended care and how their control is. So using the lab data, we were able to capture some data on people who'd had a hemoglobin A1C, which of course reflects the glucose control over the last 3 months or so. It doesn't have complete population capture. We don't have the data from some of the private labs. But in those individuals who had at least one hemoglobin A1C that we captured, control was not optimal. So only about a quarter of First Nation Manitobans and only about 40% of all other Manitobans had an average A1C under 7%. So this is concerning, because this is kind of like our most general measure of whether people are maintaining control of their diabetes. As we know from within health and outside of health, control of type 2 diabetes is a thorny problem. It involves strategies from within the healthcare system, from without the healthcare system, and is strongly impacted by both social determinants of health and then for the Indigenous population, for the Indigenous determinants of health, and that the ongoing effects of systemic racism and poverty, food insecurity, loss of connections to the land and local languages, all of those things impact a person's ability to control their diabetes. But again, this is an area where small gains are going to make a difference. Those of you who know Pat Martin, I must pay homage to her in this slide. What this slide shows us, the distribution of average A1C for the population with type 2 diabetes. So the darker green is all other Manitobans. The lighter green is First Nation Manitobans. And we can see that the distribution is quite widely spread, with a large bulk of the population having their numbers above our goal here of 7%. If we could just squish this together and shift it a little to the left, we would have better outcomes. So while the report itself didn't look at, the ways to achieve better control of type 2 diabetes, we know from the literature that there are multiple evidence-supported methods, which include the use of a chronic care model in community clinics. The bulk of type 2 diabetes care for adults is provided by primary care providers. And so capacity for those primary care providers needs to be built. We need to look outside the healthcare system to improve glucose control, address food security, safe physical activity, educational support. And we would advocate for cooperation between different government departments because, again, type 2 diabetes is not just a problem of health. Liz has, spotlighted the problems with the increasing rates of type 2 diabetes in children. The report also showed that, of course, those children turn into young adults and that young adults are not well connected to the healthcare system. Young adults, especially young men with type 2 diabetes, are not even meeting kind of the bare minimum contact with the healthcare system. We see up to a quarter of young adults have no physician visits captured in the last year within the repository data. Those with lower contact rates for healthcare have lower rates of receipt of recommended screening and higher hospitalization rates. And that the First Nation Manitobans have lower contacts with the healthcare system than all other Manitobans. And that holds true outside of areas where we know that unfortunately we don't capture nursing station contact. It's not just in northern and remote areas that people living with type 2 diabetes are not having contact with the healthcare system. And so we would advocate that for different communities, different methods of connecting people to the healthcare system are important. And when we talk about this slide, Lorraine would always say, because we talk a lot about how the care of diabetes includes more than healthcare, but healthcare is the first step. And she would always tell us, if you're not contacting the healthcare system, then we need to work on that in addition to all of the other things that are impacting people's control of diabetes. Perhaps one of the, when we think about diabetes and the complications of diabetes, two of the complications that spring most to mind, I think, are kidney failure requiring dialysis and limb amputation. So end-stage renal disease is a very expensive and life-limiting complication of type 2 diabetes. We know that progression to end-stage kidney disease can be slowed with screening and other treatments. And it's an area where the discrepancy between First Nation Manitobans and all other Manitobans is very wide. So almost 5% of First Nation individuals living with type 2 diabetes are in end-stage renal disease. So they've had a kidney transplant or they're receiving dialysis. And that number is about 1% of all other Manitobans with type 2 diabetes. This is an area where the Manitobans are not receiving the care that's recommended by the Diabetes Canada guidelines. Every year, a person living with type 2 diabetes should receive a urine ACR screen. And only about half of the people currently living with type 2 diabetes had a urine ACR screen captured in the data. And this test we do have complete population capture of because of the way that the labs are run. As we noted before, young adults, as low as 40% of young adult males are not receiving their ACR screen once a year. ACR screens are one area. So when we look at, as we see in this slide, when we look at areas where there are targeted programs to make sure that people are receiving their screening, such as in some northern and remote areas, and in the areas serviced by the Diabetes Integration Project, we actually see higher rates of ACR screening. And so the north, for example, this is an area where their screening rates are actually better, you know, over 70% for First Nation Manitobans living with type 2 diabetes. And in areas where, you know, we would think that travel or contact with the health system, such as in Prairie Mountain or Winnipeg, where our numbers, you know, where it shouldn't be as hard, our numbers are lower. And in many health regions, the numbers for First Nation Manitobans are better. So despite receiving screening at a higher rate than all other Manitobans, outcomes are substantially worse, which again points to the fact that it's both the healthcare system and factors outside of the healthcare system that impact type 2 diabetes outcomes. We looked in the deliverable at how well people were connected to a consistent primary care provider. And we found that when people had, you know, more consistent primary care, that they had higher screening rates and decreased hospitalizations across most indicators. Continuity of care was higher for all other Manitobans than for First Nation Manitobans. It was a little bit lower in the north and higher in Interlake than in the Manitoba average. As I said, there was a very strong, consistent gradient between continuity of care and screening, as well as things like flu shots and screening like retinopathy screening and kidney screening. There was a slightly more complicated association between continuity of care and decreased hospitalizations. People in the highest continuity of care bracket had decreased hospitalizations, but however, also people in the where we were unable to assign them a primary care provider because they had very low contact with the healthcare system, they also had lower hospitalizations. So there's more of a story there than we kind of were able to tease out in the deliverable. But again, there are patterns that suggest that aiming for more consistent primary care may be a way to improve outcomes. As we've alluded to throughout this presentation, and as is seen, you know, consistently throughout the report, the adult First Nation population with type 2 diabetes had higher rates of death and complications than all other adult Manitobans. And again, this was within a setting where often screening tests and primary care attendance were similar and in some areas higher. So this again just supports this idea that access to care is kind of the minimum threshold, and that access to care is only the first step. That care needs to meet the needs of the communities that it's serving, and it needs to be able to address things both within and outside of the healthcare system. So as we mentioned a little earlier, this is the slide that shows us that there really is no gradient in premature mortality rate across the health regions. We see a consistent difference between First Nation Manitobans and all other Manitobans, but when we look across the health regions, the numbers are the same. There's no statistically significant difference, which suggests that the kind of things that often drive the differences in mortality across the health regions, that the bulk of that may be coming from people living with type 2 diabetes. So again, outlines the importance of addressing type 2 diabetes in our population. Another thing that we found that I think deserves kind of more future study is that when we look at the cardiovascular health of people with type 2 diabetes, when we look at the kind of earlier stage complications, so hypertension, high blood pressure, and angina, chest pain, we see a difference between First Nation Manitobans and all other Manitobans, but the difference is not very large. So the rates are somewhat similar. But when we look at the kind of more end stage complications like congestive heart failure and heart attacks, we see a much larger difference between First Nations and all other Manitobans. So to me, this suggests that we're either not capturing or so we're not diagnosing these earlier stage complications when perhaps we can do things to intervene to stop progression to the kind of more end stage complications. When Lorraine sees this data, she would tell us that she worries that this talks about the fact that due to how overworked and the short amount of time our primary care providers have to see a person at an appointment, they're focusing only on the higher end stuff and not the kind of earlier stage stuff. And so we're missing an opportunity to intervene. Another area where we see a difference in contact with the healthcare system is when we look at specialist visit rates. So while the bulk of kind of basic care for diabetes falls to primary care providers, as we know, many people living with type 2 diabetes also need to see specialists, cardiovascular specialists, endocrinologists, and other specialists, kidney specialists. But what we see that despite knowing that First Nation Manitobans are sicker than all other Manitobans, the contact rates for specialists are lower for First Nation Manitobans than for all other Manitobans. Except in the north, where we see that rates for First Nation Manitobans are higher. And again, this reflects areas in which we have specialized programs to increase the specialist visit rate. In Island Lake, where there's a coordinated program to provide specialist care in the community, we see substantially higher rates of specialist visits. And so again, it reflects that targeted programs work. So the bulk of the report focuses on the whole population living with type 2 diabetes. And then some of the report talks about some kind of more specific outcomes in matched cohorts for children, pregnant women, and adults with type 2 diabetes. And now we're back to Liz.
Good. Thanks, Chelsea. So in the pediatric population, we were able to take the cohort of children with type 2 diabetes, compare them to a cohort of children with type 1 diabetes, and most importantly, we were able to compare them to a cohort of children without any diabetes, matched for age, sex, First Nation versus all other Manitobans, and geographic residence. So they were matched to the children with type 2 diabetes. So we were able to compare children with type 2 diabetes essentially to their peers, to children who live in the same region, who are either First Nation or all other Manitoban of the same age and sex. And when we did that, we found that First Nation children, well, we have already told you First Nation children are disproportionately affected. We found, and I'm going to show you the more granular data in a minute, that children with type 2 diabetes carry a very high burden of illness compared to their matched peers and compared to children with type 1 diabetes, both before the diagnosis and after the diagnosis. And the same is true when we look specifically at mental illness. Children with type 2 diabetes have high rates of mental illness compared to their matched peers and compared to children with type 1 diabetes. And of course, this likely impacts their ability to be involved in self-care behaviors. If we look at the next slide, this is just some specific data looking at hospitalization in children with type 2 diabetes. So when we compared children with type 2 diabetes to their peers, so their diabetes-free matches, they are more likely to be admitted to hospital in the year prior to diagnosis and in the first year and the 5-year period post-diagnosis compared to their peers without diabetes. You'll see that in the first year and the first 5 years, we've included two things, including diabetic ketoacidosis, which is an acute complication of diabetes. And even when we excluded that they are more common than their peers to be admitted to hospital, both in the first year and in the 5 years post-diagnosis, but very importantly in the year prior to diagnosis. We think that reflects comorbidities of children who have type 2 diabetes. Type 2 diabetes is the least common complication or component of the metabolic syndrome. Most kids who live with type 2 diabetes live with more than one chronic illness. They live with type 2 diabetes. They have a very high rate of living with obesity. They may also have hypertension, dyslipidemia, and other complications they developed before developing type 2 diabetes. We see a very similar pattern when we compare children with type 2 diabetes compared to children who live with type 1 diabetes, both the year prior to diagnosis and in the first and the first 5-year periods post-diagnosis. They're much more likely to be admitted to hospital, even if you exclude the acute complication of DKA. So the next slide is specifically looks, I'm just going to share with you the relative risks of mental health comorbidities in children with type 2 diabetes. And this is compared to their diabetes-free peers. So compared to their friends who live in the same communities of the same ethnic background, age, and sex. And before diagnosis, they are more likely to be diagnosed with a mood and anxiety disorder. They're also more likely to be diagnosed with a mood and anxiety disorder after diagnosis. Substance abuse did not differ between the two groups, but both we lumped completed and attempt suicide together. And before diagnosis, they're more likely than their peers to have either attempted suicide, and post-diagnosis, they're more likely to have attempted or completed suicide compared to their peers. And both before and after diagnosis, they're more likely to have been prescribed an atypical antipsychotic medication. So just giving you a flavor that these kids carry a fairly high burden, both of hospitalization, reflecting perhaps medical comorbidities, as well as mental health comorbidity. And this is pretty original data. There's very little there's almost none out there related to hospitalizations in youth with type 2, and very little in terms of mental health comorbidities. Both issues that are going to be important for planning resources, but also how we approach care and support of youth living with type 2 diabetes. And I'm going to pass it back, I think, to Chelsea.
Yeah, thanks. So, and again, there's more data on kids living with type 2 in the report. We have just a highlight of some of the data that we looked at for pregnant women with type 2 diabetes, because of course, as the age of diagnosis goes down, we're going to see more and more people carrying a pregnancy while they are living with type 2 diabetes. And this is the area closest to my heart. And it also an area where we don't have a lot of data kind of outside of, what happens to the babies when they're first born. So we know that pregnant women utilize a lot more with type 2, use a lot more health care resources than those without. And First Nations women that are pregnant already are at higher risk than all other Manitoban women. And then the diabetes kind of increases that risk again. So we end up with like a staggered ladder where First Nations women have a higher risk, as do women with type 2 diabetes. And so the risks just continue to compound themselves. Women living with type 2 diabetes are almost 3 times more likely to be hospitalized before delivery. Their babies are more likely to require an NICU admission. Their babies are more likely to be born preterm, and mostly preterm in that what we call late preterm, so kind of 34 to 36 weeks of gestation, often because they're very large and they need to be delivered before they get too big. And they're at significant risk of stillbirth if you let them go too close to term. Women living with type 2 diabetes have a much higher risk of delivering outside of their health region. The only hospitals in Manitoba that can provide this level of neonatal care that the babies need when they're born a little bit early or a little bit too big are Winnipeg, Brandon, and Thompson. And so unfortunately, a lot of women end up being relocated. So if you think about it, they have a pregnancy, and so they're maybe in the hospital 2 or 3 times during the pregnancy. Then they have to relocate to Winnipeg or Brandon or Thompson near the end of their pregnancy to have their delivery. and then their babies are born and their babies need to stay in the nursery for a week or two. So you think about how much time that pregnant person is away from their family. First Nation women are already being relocated to areas outside of their health region. And there's a long history of forced relocation for Indigenous women outside of their home community to deliver. And so we're, even without trying to, we're continuing that by having First Nations women living with type 2 diabetes having to relocate to have their babies. As I'm sure many of you know, our perinatal system is at capacity even before COVID. And so we really do need to look at expansion of programs like the antenatal home care program and expansion of the ability to handle babies that are just a little bit sicker than a regular baby closer to home. So we looked additionally at adults living with type 2 diabetes compared to adults living without any diabetes. It's some of the same indicators that Liz talked about for the kids. And again, we demonstrated there is a well-known burden of mental health disorders in adults living with type 2 diabetes. It's better described than the complications in kids. And we kind of demonstrated in the Manitoba population the same findings. We saw an increased risk of suicide attempts and mood and anxiety disorders in people living with type 2 diabetes. We saw a higher use of atypical antipsychotic medications. And so, again, it supports this kind of bidirectional approach to mental health. People living with type 2 diabetes, part of type 2 diabetes care is screening for mental health disorders. And in people living with a mental health disorder, we need to make sure that we're screening for type 2 diabetes. So what do? I think that's why we're all here today. We really recommended within the report that we need an integrated provincial strategy. We need earlier and updated screening for type 2 diabetes. We need programs targeted for different groups and different outcomes, because how you manage a 70-year-old man with diabetes is very different. Type 2 diabetes is very different than how you would help a newly diagnosed 17-year-old in her first pregnancy to manage her diabetes. We need cross-disciplinary programs, both inside and outside of health. We need to build capacity in primary care where the bulk of diabetes management or type 2 diabetes management for adults occurs. We need to ensure that we have continuity of care and support for ongoing screening for complications and comorbidities. We need to build community and rural capacity to manage pregnancy in people with type 2 diabetes. And as I mentioned, we need that bidirectional focus on mental health for people with type 2 diabetes. So those are the highlights that we thought we would talk about today. That's my contact info. Lorraine McLeod, our FINISM partner, who unfortunately wasn't able to join us today, and Liz's contact info at Health Sciences Center. Thank you all.